This is my great pleasure to be able to discuss today part of the field of ALK-positive non-small cell lung cancer treatment paradigm. My name is Solange Peters. I'm the Director of Oncology at the University Hospital of Lausanne in Switzerland. And I will focus here on biomarker testing and a little bit the old days, if you allow me to say, the historical management for positive ALK-positive non-small cell lung cancer. We will, of course, discuss also in this occasion the innovation, but I will go back a little in time to look at what we were doing before. So case number one, I have two cases. It's about biomarker testing and the importance of testing even in early disease. This is a 63-year-old lady, never smoker. So this should be something which resonates in your mind. An ECOG of 1 with chest pain and very, I would say, vague symptoms, cough, loss of appetite and weight for 3 months. She has only a diabetes and she's seen by the physician who, after some weeks of observation, decided for a CT scan. And as you can see on the CT scan, there is a right lower lobe mass, which is very visible, but without any lymph nodes to be seen on the CT scan. The biopsy was done, a transthoracic biopsy showing an adenocarcinoma, no doubt about it. And the PET CT was not showing anything else. So no lymph node and still this lesion close to 4 centimeters, slightly under 4 centimeters. For sure, we made an MRI of the brain, which was negative, and we could do an EBUS to make sure that the mediastinal lymph nodes were not positive. It was not the case, meaning that the clinical stage was T2A and 0M0, which is stage 1B, according to the 8th TNM classification. The lung function were good, of course. She was a never smoker, and the heart function was also absolutely adequate for surgery. So what else do you need? Are you going to surgery right now, or did you miss something? So let's move to the theory behind. So first of all, biomarkers in non-small cell lung cancer. So we start from the histological classification. I don't want to be boring. You know it. It's a TTF1 and so on. This is done routinely by all pathologists around the world. But from there, we moved in the non-squamous non-small cell lung cancer in defining a series of what we call drivers. Now we call them AGA to be more fashion, which means actionable genomic alterations, which are very important because they drive of course, a malignant phenotype, but they are, as the name is saying, actionable. So we have drugs against in order to correct these alterations. So there are a series of more or less 12 alterations that you need to look at in non-squamous non-small cell lung cancer. Of course, you have to look at PDL1, particularly if you don't have AGA, actionable genomic alteration. And we all wonder to know if you have other protein expression to measure in the future to look at antibody drug conjugates. This is a question mark we still don't know. But basically, look at my case. We were a little short in looking at all of these parameters. And this is the table, and just look at it quietly about in yellow, what is recommended. SCAT1 and 2 means it's an actionable scale, an actionability scale done by ESMO. But 1 and 2 means you have a good drug. 1 is evidence-based, 2 is almost phase 2 randomized. So you really have good drugs, and you need to look at ALK, BRAF, EGFR, MET, NTRK, RET, ROS, EGFR, exon 20, HER2, KRAS, and MET have to be looked at. Then you have all what can be emerging or exploratory. I just have put them on the table because you will hear a lot about them in meetings about translational research, thinking, for example, about Notch, STK11, and the tumor mutational burden, just taking examples. When you think about biomarkers, it's not straightforward, right? We cannot invent them because some are just mutations. So sequencing will be enough. And the best way to sequence in a multiple fashion with multiple pistes is to do NGS, right? And this is true under the column of mutations. But some are not mutations, but chromosomal rearrangement, what we call rearrangement or fusions. And this, as you will see on the next slide, it can be done by NGS, but some look at what is rearranged, meaning looking at the RNA, the messenger RNA. And sometimes we would like also to look at protein expression, think about PDL1, think maybe at the future of antibody drug conjugates. So the problem is you need probably an NGS, probably an NGS with RNA, and if not, you need to complete with a FISH assessment, and you need an immunohistochemistry. And just to explain to you about why you need DNA or RNA, when you have really large introns, it might be that in the DNA you cannot see the fusion, so you need to see the fusion being done as a messenger RNA, and that's why you need to look at the RNA. And there are many scenarios in which you will lose to up to half of the MET exon 14 or the RET rearrangement if you use the old day DNA NGS. So keep this in mind when you speak with your pathologist, but your pathologist, I'm sure, is doing it right. The last question we have in lung cancer is liquid versus solid biopsy. So in Europe, it's not so much of a problem because in Europe, you are reimbursed only for one. So you need to choose what is the most sensitive, and the one you need for also legal purpose is a biopsy. So in Europe, you need a good biopsy. But in the US, what I know is my colleague like to do both in parallel, because you might, first of all, be more sensitive using both, and you might gain time because very often you will read the liquid biopsy before you have finished to accomplish your biopsy and sent it for NGS. So they are allowed to do both, and I think it's very nice complementary methodology. So plasma first, both together, or only at resistance. It might be the scenarios that you meet in your daily practice or your daily questioning, right? And this is what we have in ESMO guidelines now, what you need to look at. So the first line is showing you these TKIs, which are now frontline TKIs. So ALK TKI, GFR TKI, ROS1, RET. In the second line, for MET exon 14 and KRAS G12C in Europe, it's still second line treatment. So they are on the clinical trials, but you still have to start first with chemo or chemo IO. So that's more the paradigm of Europe, but all of these are actionable genomic alteration that you need to look at because you have very good drugs. Okay? And why do you do that? This is a very old publication, but basically, if you sequence yes or not, at the time there were way less, by the way, oncogene addicted strategies, right? You will improve the survival of your patients. So by just pushing back the chemo or the chemo IO to a second line setting, introducing a tyrosine kinase inhibitor first or a targeting inhibitor for KRAS, you will prolong the PFS and at the end prolong the survival of your patient. So at the time of sequencing, we have started to improve survival of our non-small cell lung cancer patients. And this is thanks to this long list of compounds. And every time we meet on the phone, Dr. Love, it is longer because it's kind of growing over time. But that's what also is called innovation and the paradigm of having drug developers helping us making first, second, third, fourth generations of drug with more specificity, brain penetration, as well as a better affinity for the target. Okay, so let's look at my case. Are we satisfied? So we went to surgery for this patient, right? And the pathology was showing the 3.4 centimeter lesion, still an adenocarcinoma of the lung. Nothing changed here. Unfortunately, we had an N1 disease, right? So it was not N0, but N1. You had a Hyler node positive. The mediastinal lymph nodes were negative. And the ALK was negative, ROS was negative, but we had an NGS showing an EGFR mutation. So the final stage is a stage 2B because of the N1. And in this patient, we plan adjuvant osimertinib from the ADAURA trial because it improved DFS, but also overall survival. But what would have happened if I had decided to jump into an immunotherapy in the neoadjuvant or in the adjuvant setting? And if I hadn't been testing this non-small cell lung cancer early disease, I might have taken the wrong decision, particularly because remember, osimertinib doesn't match with immunotherapy. So if you start first with immunotherapy, then you cannot give osimertinib. So remember that in early disease, adenocarcinoma, or at least confident non-squamous, you need to test for oncology, oncogene addiction, AGAs. You have a question?
This is an actual patient of yours?
Yeah.
I'm curious, what's the patient's current situation?
So still under osimertinib, we discussed compliance before, to adjust a little bit the compliance to make sure she's now taking it in the evening because she was feeling more comfortable doing that. We adapted a bit all the medications around, but still under the drug. The main question always of patients, and I think it's a very nice one, is to know why a certain number of years and why stopping at some point. And I don't think we have the answer, right? But still under the drug at the time being, it's not so long. So at the time being, it's less than 1 year. So all good.
When you said you thought the main question was, I thought you were going to say, because my question was, did you offer chemotherapy to her?
Yes, always. Sorry for that. I always offer still chemotherapy for ALK or EGFR early disease because I think we have this long follow-up from the latest meta-analysis, but also each single individual trial of adjuvant chemo showing that you cure more patients, right? So that really, if you look at 10 or 15 years, and the real number is 5%, you cure 5% more patients. So for this patient with nodal positivity, I tell them that I'm a bit old-fashioned. I think adjuvant chemotherapy, we know, is curing patients. We still don't know with TKI. It's prolonging survival, but we don't have enough time to tell that it is about cure.
The reason I asked is that, you mentioned, you bring up, a lot of times people are very sensitive to numbers, and that's what it's all about. In the adjuvant, all you have is numbers to give to a patient. And the thing is, when you give the number of 5%, but you're knocking out 80% of the recurrences with your targeted therapy. So is it really fair to say it's 5%?
The main question is really to know with your TKI if when you stop, you will not see after 1 or 2 years a whole group of relapses, right? Which means that it's just prolonging survival and not curing. But more importantly, even if you are a breast cancer expert too, even if the TKI brings your survival curve very high, what is important is how much you gain in the remaining proportion of relapse. Imagine that you have 80% cure rate, fine. So if you can still gain 5% out of 20% relapse. So you have an increase in survival of relative of 25%, right? So what I'd like to see here is the hazard ratio and not the absolute number. The more you cure, the more this little percentage will mean something for patients, right?
I always have this argument with lung cancer people. But anyhow, the other thing I was curious about is that you were talking about you using electronic monitoring and for adherence. Do you do that in your routine patients? Like, did you do that in this patient?
Unfortunately not. We don't use it in routine because it needs a lot of capture and we do it only under the concept of a trial. So we are now moving to the next trial, which should be led by pharmacists. So we expect our pharmacists to lead the trial to be spread over the country. So this will come soon, but at the time being, it's not ongoing. So he has the usual osimertinib pack.
All right, well, let's talk about ALK, and I'm going to ask you the same question about chemo here, but now you've got alectinib versus chemo, so it's a different way to look. Just out of curiosity, before you get started, do you usually give chemo to your ALK patients too?
So you're right that in the ADARA trial, we had the choice to give or not the chemo. So meaning that you still have your expert opinion. If you want to be evidence-based, for the ALINA trial, it was chemo versus adjuvant alectinib. So if you are evidence-based, you are not supposed to give chemo. However, I still give chemo. And I think most of our lung colleague experts would maybe discuss it with the patient, but still would be adherent to the idea of adjuvant chemotherapy in this patient population. Also because we all feel like it has a certain relapse rate after surgery, which pushes us to make everything we can to prevent it. But I think most of us would still give chemo, at least discuss it with the patient. And remember, the chemo in ALK is platinum pemetrexed. And pemetrexed is amazingly efficacious, specifically in ALK disease. So maybe the chemo has more than 5% impact there. I don't know, no numbers, just an hypothesis, but it might be slightly better even here.
Really interesting. All right, please continue.
So let's speak about ALK. So this we will discuss it throughout this session, but we have to remember that the ALK patient has nothing to do with the lung cancer patient who we're used to see. It's very often a woman, an adenocarcinoma histology, but most of the cases are light or never smokers. I had a patient 16 years old last week, so something that you never expect to have seen in lung cancer before, at least were not diagnosed. And very importantly, the prevalence and the incidence of brain metastasis in the course of an ALK-positive disease is very high. Reason why several generations of drugs were developed, because it was the drama of ALK-positive non-small cell lung cancer patients ending up almost 70-80% of them with brain mets at the end of the story. So have to keep in mind that more than a third of the patients have brain mets at initial diagnosis, right, which is twice more than expected in unselected patients. What was nicely shown in the early days, 2011, as you've seen, is it's interesting that probably ALK has not so much of a prognostic impact in advanced disease, right? But of course, it's completely different if you have an ALK TKI. You will change, as I said before, the survival of this patient. So before the era of ALK TKI, they were probably having something similar as a survival as the all comers. But when you have suddenly crizotinib at that time, you completely change the outcome of these patients because you have another additional efficacious line of treatment. And we also looked, of course, at several surgical patients to try to see if ALK had a positive or a negative prognostic impact. So if you look at all the literature, 50-50, most of the series show nothing or positive impact, slightly positive as we did it in this Longscape trial, but some also show a negative impact. So what I would say in that, nothing really evident, obvious, or stringent in terms of prognostic impact, but a question to be solved. The small numbers makes the field very confused because it's very small number of patients. So we started with the field of metastatic disease to compare the all-day crizotinib with chemotherapy. It was improving survival, PFS, sorry, PFS, be very careful, of 3 months from the usual 7 months for the chemotherapy to 10 months for crizotinib, and all the subsequent trial will show 10 months PFS for crizotinib. And that's where we were coming from. But very rapidly, we moved to second generation, even third generation ALK-TKI, which have the characteristic of having, as I said before, a better affinity for ALK. Even ALK protein, where they have a second mutation, secondarily mutated ALK proteins, they have also a better brain penetration, right? And when I say it's a better affinity for the target, it means also very often better specificity, so a lower toxicity profile for most of these compounds, right? So quite interesting generation after generations of drug, which translated into comparison to crizotinib, of course. Alectinib was better than crizotinib, brigatinib was better than crizotinib, and very recently, the newest generation of drug, right, lorlatinib was better than crizotinib, with, as you can see, an improvement in the separation of the curves versus crizotinib, which becomes more obvious using lorlatinib. So we'll discuss it, and we'll discuss, of course, the side effect of lorlatinib later on, I'm sure. So this is the ESMO guidelines. Of course, ESMO guidelines proposes based on evidence using all this, alectinib, brigatinib, or lorlatinib frontline. But we'd like to discuss today what to do when these drugs fails, right? So I use brigatinib, I use alectinib, I use lorlatinib frontline. I think it's very rare today that we use crizotinib frontline. So let's think about this second generation frontline. What can you do later on? So let's keep in mind that in general, when you think about unselected patients, between 10 to 60% of the patient only have one line of treatment. And when we speak about ALK, probably a third of the patients have only one line of treatment. So the strategy of best treatment first is very rational here, because there is a high probability that you have only one chance to give the right drug, right? And if you think about why don't you offer a second line treatment to ALK patients, the reason most of the time looks like to be a very rapidly progressive disease. So the progression in ALK disease might be very fast, and very often including the brain, okay? If you think about giving first a TKI, crizotinib, ceritinib, alectinib, or lorlatinib, the resistance mechanism using this drug is sometimes in a third of the patients what we call ALK dependent. So meaning a second mutation of the ALK gene, which will bring a non-binding of the drug, bring a resistance mechanism, which is really on the ALK protein and on the ALK binding side of the TKI. And as you can see, it varies according to the drug, but more or less 1 patient out of 3 have an ALK-dependent mechanism of resistance. Here you have the lorlatinib pie on the right. Be very careful. Then this is the case, more or less a third of the patient with ALK-dependent, but only when lorlatinib is not used frontline. I will show you later on that it's completely different when you block ALK with lorlatinib frontline. But that's what we have with these TKIs. Of course, when you reach this point, you can use chemotherapy, you can sometimes use radiotherapy, and you can imagine to use immunotherapy, or at least you need to evaluate it. These are the pillars, the usual pillars of cancer treatment. So first of all, why radiotherapy? Because of oligoprogression. oligo persistent sometimes, but let's speak about progression, so oligo progression. There are now 3 or 4 series showing that when you have a progression of your disease only in 1 or 2 sites, very often lymph nodes, but it can be an isolated clone of resistant cell, there is a reason to irradiate this site and continue the same TKI. We know it from EGFR, but you can transition it to ALK without any problem, or to all oncogene addiction, addictive non-small cell lung cancer. Would it be in the brain, which is easy, but would it be also in the bone or sometimes in the lymph nodes? This is a good strategy to gain time, right? And gaining time, we remember, is gaining survival. And let's keep in mind that in ALK, very often the progression was the brain because of this propensity to go to the brain. So just irradiate by stereotactic radiation of the brain and maybe continue the same TKI. What about chemo? We had very few data about the activity of platinum pemetrexed specifically in ALK at progression. So Dr. Lin and colleague have pulled what they knew from their patients being treated by a TKI, followed by chemo. So the response rate is 30% with platinum pemetrexed. The duration of response is 6 months. And there is something which is not routinely done, but if you continue your TKI with chemo, it looks better than stopping and going to chemo only. But of course, this is not today registered. But basically, response rate 30%, duration of response 6 months is what you expect from any chemo frontline in non-small cell lung cancer. So a good option, right? What about immunotherapy? So we have very few data about immunotherapy in ALK disease. You can see that there are very small ALK sample size in immunotherapy monotherapy trials, and most of the time ALK subgroup is not reported because too small. We still have this wonderful paper from Julien Mazière, the immunotarget, looking at small number of patients, but what does monotherapy bring in terms of responses in late lines in these AGAs? And you can see ALK, it's 23 patients, and response rate is 0%. So, and not really promising in ALK, you will agree with me. It's way more promising in KRAS, for example, right? But in ALK, at least as monotherapy, is not efficacious. So what else do we have? We have these trials trying to pile up many things: chemo, IO, anti-angiogenic, in patients, all comers, but including ALK and EGFR. So one is the Empower 150 with atezolizumab and bevacizumab, and the other one is the Atlas trial, which is another generation of trial, also using atezolizumab and bevacizumab, but really focusing on trying to establish it at the regimen, notably in oncogene addiction. So I will just show you what we have, very small data set. On the left-hand side, the Empower 150. As you can see in that trial on the forest plot, there were some EGFR and ALK patients which looked to benefit also from this strategy as compared to the BEV chemo to a certain extent. And when you look at the number of ALK patients, it was a very small number of patients, 34 altogether, but still, why not? It might be an option to deliver IO with combination with bevacizumab. On the right-hand side, the Atlas is slightly better because the control arm is only chemo. You don't have bevacizumab. And again, you can see a little kind of benefit by doing that as compared to chemotherapy. But when you look at ALK, it's a very small number, and this subgroup was not reported alone. So EGFR was improving PFS, but ALK, we don't know. So that's what we have for immunotherapy use. What else for immunotherapy? So you pile the TKI plus immunotherapy, so ceritinib, lorlatinib, alectinib in the same time of immunotherapy. So the answer today is no, because first of all, you don't improve the response rate, you don't improve the PFS, and you don't improve the durability, which would be the main thought, right? Increasing the durability, and it's not the case. What you have is unexpected toxicities, right? Liver toxicities, and sometimes very, I would say, discouraging GI toxicities. So basically, not so much option. So if you want to use IO, it's limited. It might be with chemo and anti-angiogenic, but still, I think this is a matter of debate in the community. Many of my colleagues would say no IO for ALK-positive non-small cell lung cancer. So what else do you have in second, third line of your strategy? So the antibody drug conjugates. Now we have one which is amazing, the datopotamab deruxtecan, so a topo-1 moiety in terms of chemo and binding to this TROP2 a protein which is overexpressed in 80% of non-squamous non-small cell lung cancer. And this was testing in all comers, even in randomized phase 3 trials, but specifically in these patients with actionable genomic alteration in the trial called TROPION Lung 5, dedicated to actionable genomic alteration. I drive you to the second slide where you can see all the patients with a response rate of 35%, patient with EGFR mutations 44%, and patient with ALK rearrangement 24% of response rate with a PFS of 4 months. So not completely exciting, but I like the spider plot because you can see a response. Some of these patients were really in late line, second, third, or fourth line of treatment. So I think let's keep in mind that antibody drug conjugates might in the future represent options to deliver late-line chemotherapy in a very specific fashion in oncogene-addicted non-small cell lung cancer, including ALK-rearranged non-small cell lung cancer. But of course, again, here we don't have biomarkers. TROP2 is not measured, so maybe we can refine later on. Okay, so I think we can just move rapidly to early disease. So what about early disease? So why to test for early disease? So we discussed it before. We'd like to do better in early disease because the cytotoxic chemotherapy improves survival 5.4% only. And when you do surgery in lung cancer patients, depending on the stage, right? But basically half of your patients will relapse. It's not breast cancer. Here, half of your patient will relapse. It's a lot. So you have all now of an algorithm telling test, test, and test. So first of all, test in the initial biopsy. Go to your tumor board, look if it's resectable or not. If it's resectable or not, you can go to neoadjuvant treatment, but you need to test for EGFR and ALK before. And after surgery, you need to confirm with pathology what you still have as a tumor, but also to make sure that you haven't missed any oncogene addiction. So now the testing is everywhere, including in the guidelines. There are several opportunities to test. And be careful about one thing. You need to know because if you have given immunotherapy, you cannot give targeted therapy later on, as I said before. And this is the guidelines. The guidelines, NCCN guidelines, tell you in the initial biopsy, you need to test for EGFR, for ALK, and for PDL1. The ESMO guidelines say the same, and the other guidelines are more or less kind of creating a new version and implementing it. So I think this is routinely what we will have to test. The ALK, EGFR, PDL1, probably ROS, maybe some other biomarkers too, because ongoing trials are still to be finished and completed. But at least at the time being, you need to test more and more. Remember that we have immunotherapy in the adjuvant, pembrolizumab, atezolizumab, neoadjuvant, nivolumab, or perioperative, meaning before and after. We have these strategies. I will just drive you through the adjuvant trials. On the left, atezolizumab in the adjuvant stage 1B to 3. On the right, pembrolizumab. Very similar curves, right? So what about EGFR and ALK in these diseases? So they were allowed. Surprisingly, they were allowed in the adjuvant trials. You can here look on the upper panel about the ALK patients had that ratio 1. So not sure that atezolizumab improves, even if it's a small subset, the outcome of this patient. And the Keynote 091, there were very few number of ALK patients, as you can see, but they were not described separately. Only EGFR, but no ALK, so we don't know for ALK. So again, you might have better to do, and I know Dr. Solomon will tell you, you have better choices to make. But if you think about all of these perioperative trials, this table is for you. Remember that most of the trials were not allowing for EGFR and ALK. So only one, the Keynote 671, was allowing that. The other ones did not. Keynote 671 is pembrolizumab before 4 cycles of chemo IO followed by IO. And in that trial, it was allowed, but at the time being, we don't know anything about the ALK subgroup, which will be extremely small at the end. So this is basically what we know for early disease and immunotherapy. And as I said before, Dr. Solomon will tell you more about what to do. Immunotherapy is potentially what not to do at the time being. So let's go for a specific case, number 2, a case maybe about what not to do. It came from a colleague that I met at a meeting, and he gave me the case. I love this case. It's a 61 years old non-smoker. Think about it, housewife without any exposure history. She complained for symptoms in swallowing for 10 months, right? And then she had such a weight loss that she was admitted to a cancer center. They detect this amazing mass, which is compressing the esophagus, probably even invading the esophagus. And the bronchoscopy was done, but it was very difficult to reach the lesion, right? You couldn't reach really the lesion. So basically, she had a PET CT with no other lesion detected, and a punctures by ES through the esophagus was allowing to give the biopsy of an adenocarcinoma with an ALK rearrangement, the classical one, the version 1. It was a CT4 because it was invading the outer layer of the esophagus, CM0, but a stage 3B. So what to do here? Some surgeons' mind would say maybe it's operable. Most of the surgeons would say no because the esophagus is in the tumor, so very difficult to say. So the local doctors say, okay, so let's start with a TKI. So let's start to give alectinib and we'll see if the patients because are operable. Is it right or not? I don't know, but that was the best middle way. It's a gray zone for sure. The other option would have been to give chemo radiation, but of course, with a poor outcome in that setting and a lot of toxicity. So was the decision correct or not? I don't know, but that's what happened. A lobectomy of the left lower lobe and systemic lymphadenectomy was done by minimal invasive technique after the last dose of alectinib, which was given for 2 months, and the pathology was showing a complete response. So the main question here is how to continue. You give 4 cycles of chemo, you continue the alectinib for an additional 2.5 years, you give radiation because still you're not sure it's complete. So the problem is it's outside of the evidence-based, so you don't know what the evidence should tell you to do. Was it right or not? I don't know, but at the timing, the patient is doing well. I asked my colleague last week, it looked like the patient is still without disease, and he continued alectinib for an additional 1.5 years in this patient. So that's the case number 2, lots of question marks here.
That's a great case. If I could, just a couple questions about that case. One is the question of, does surgery or any kind of local therapy help a patient who's had a path CR to neoadjuvant therapy? And also, when you got down to after the surgery, what to do? And of course, the question comes up about cell-free DNA, either today or in the future, to try to answer those questions.
So the first question is very interesting, the value of pathological complete response. So first of all, there were some, when you were using neoadjuvant IO, so maybe difficulties in defining what is a pathological complete response. It looks to me, maybe to you too, that today they have found an agreement, right? So they found a way to accurately measure the pathological complete response. But let's hope it's the case everywhere in the world. But at least in academic centers, it looks like they have the same definition. But the quality of the pathological response, is it the same when you use immunotherapy with a long-term benefit, or as compared to using a TKI? Remember, in advanced disease, if you use a TKI and your CT is cleaned, if you stop the TKI, it's terrible because the disease comes back exactly where it was before. So can you sterilize really any location using a TKI only? I'm not so sure. So if you have a big lesion, you use TKI, it becomes small. Can you reduce also your surgical field? I don't know, maybe not, because maybe it's still not sterile. So all of these questions really deserve controlled trial. I haven't seen a trial which is very large in ALK. There are 2 small ones, but there is a very important one, the NEO-ADAURA, which will look at neoadjuvant osimertinib plus minus chemo, and will probably help us understanding that. It's a gray zone. Are you really sterilizing a region by using neoadjuvant TKI? It's a real question. About circulating tumor DNA, it will be very useful. But at the time being, if you think about, in general, the data we have, it's very specific, unfortunately. Because if you have after surgery a ctDNA positive, the patient will relapse, period. So unfortunately, the positive predictive value is extremely high. The specificity too. If you have ctDNA, the game is done. You will relapse. So here you need to escalate. So we need to find ways to escalate, to give more, to do something at that point. But however, the negative predictive value and the sensitivity today is not sufficient. Probably the sensitivity is 50 to 60%, the negative predictive value 40%. So if you are negative, you are not allowed to de-escalate. So at the time being, for me, it's not ready for prime time. It's informative, but it's not something you might use to tell your patient, you have received enough immunotherapy. You don't need more. You can't do that because you will be wrong one time out of two.
So just a couple of final questions. Here's a simple one, but I'm not sure you addressed it, which is how do you approach choice of TKI, first-line metastatic disease?
Very interesting, right? So before I had the chance to see the Crown data, the 5 years follow-up, a bit before the ASCO meeting. So to be very frank to you, I called my team and I told them, don't ask me why. But today, the frontline strategy is not alectinib anymore, it's lorlatinib. And I changed it before the ASCO meeting. I have never seen a PFS curve of that kind, right? At 5 years, 60% of the patients on the lorlatinib have not relapsed. With alectinib, at 5 years, 60% are alive, but most of them have relapsed. So what I mean by that is the PFS under alectinib under lorlatinib is the same as the OS under alectinib. So you mean really it's an amazing curve and almost no brain relapse. And last but not least, if you look at the mechanism of resistance I spoke about before, none of these patients today has an ALK-dependent mechanism of resistance. So when you bind lorlatinib to the ALK protein, the tumor doesn't find any way to escape this blockade on the ALK protein. So it's an amazingly potent drug, the most, I would say, the highest affinity for ALK, also the most penetrant in the CNS with some side effects that you need to learn how to manage, that's for sure, but they are manageable, right? So for me, it's for sure the frontline strategy, right? These patients will live for, I wouldn't say decades, but probably some of them will live for decades. So me, it's a game changer.
Another issue that you mentioned, but I'm curious what you actually do in your practice, is the patient who has disease progression on a first-line TKI that you're going to switch to this chemo or whatever it's going to be. Do you continue the TKI for how long and what situations?
Okay. If the patient's progress is progressing under a second generation TKI, alectinib, brigatinib, as usually in Europe being used, I would still try. You have two choices: lorlatinib or chemo. So I like to go to lorlatinib first. I like to stay targeting as long as I can because the patient also likes to take more pills, right? And also because of the brain protection. In Europe, unfortunately, when I have exhausted TKIs, I cannot continue. I have to switch to chemo. And you can imagine the anxiety it gives to me because of the brain, because suddenly you relieve the brake on the brain. So the brain disease is coming back. So this patient progress in the brain most of the time. So I'm not allowed to continue the TKI beyond progression on the TKI with chemo. But if I would be allowed, I would continue. And the only reason is the brain protection.
And for how long?
As long as it works. So I would do the chemo, and it's chemo with maintenance pemetrexed. So I would use pemetrexed and continuation alectinib or lorlatinib.
So final question is, I have to ask you about your 16-year-old patient. What happened?
Just started lorlatinib. And it's
Wow.
quite amazing because he was a professional sport player, right? So this kind of symptoms, which are little blood. He runs less fast. He has to stop for a while during the game, and so on. So kind of a terrible situation. Yeah. Yeah, yeah. And I remember the first time we described the ALK, it was in Manchester. I remember my colleague had for the first time also a patient under 18 years old, and it sounded to us incredible, right? Something never heard about before. And, even if we think somehow might have missed it in the past, I have difficulties to imagine that we have missed lung cancer in a proportion of the patients for such a long time. So is it new? So it's really a question for me to the epidemiologist, right? Did you really miss it for a century? Or is it just a new disease, right? I don't know.
If you had to estimate the number of patients with ALK you've taken care of under the age of 18, about how many?
I remember the Italians produced some statistics. Under the age of 40 is probably a third of the patients. Under the age of 18 is probably less than 10%, right? But still, they exist, right? So probably
That's
one-digit
amazing.
percentage, but they are there, right? Yeah. Yeah.